The biggest mistake in conversations at the end of life that I see are when physicians and patients focus only on the treatments and not the goals. A conversation should never, ever begin would you like CPR? Conversation should never begin, we need to talk about tube feeding. Would you want tube feeding at the end of your life? I mean, a perfect example of this, my son is taking a course in is a freshman in college in health policy. His assignment was to talk to me about my end-of-life preferences. And he started by asking, Dad, what treatments would you want at the end of life? And I said, I can't answer that question. He said, what do you mean? I said, because it would really depend on A, the condition I was in, and B, what the likely outcomes were going to be. And where I find conversations go off the rails is when people really focus on the treatment, because that ignores the patient's goals. The other time I see conversations go off the rails is that when people try to make definite decisions. We need to do this or that now. We often don't. We can say, let's try this. Let's try this for 7 to 10 days, and if things are working, let's continue. But if it's not working, we can stop. So I often recommend a time-limited trial of therapy because I often don't know at that particular crisis point. So I see things go off the rails in two places. One is when the conversation focuses around treatment, and the second is when people don't consider that a time-limited trial of therapy might be appropriate. In an ideal world, everybody would have an advanced care planning discussion with their doctors, with their family members, with their partners, with their caregivers, with their loved and unloved ones. The reality is most of us don't. So as a palliative care physician, one of the situations that I often face and my team often faces is trying to understand how do we care for somebody in the setting of a serious illness and they haven't talked to us about it. So we ask a number of questions. If the person can talk to us, I ask, tell me a little bit about what's a good quality of life for you? What makes life worth living? Tell me a little bit about what a fate worse than death would be. If the person can't talk to me, I ask the same questions to the family member. Together, we arrive at an understanding about what is both a good quality of life and what's an acceptable quality of life. And what would that look like? For some, it's the ability to communicate and talk with family. For a minority, it's the ability to be completely independent, never have to be in a nursing home. But all of us have a different definition or a different thought about what good quality of life is. Once I gain that understanding about my patient, either from them or from their surrogate decision maker, we talk a little bit about likelihood. What's the likelihood that we can achieve that quality of life in the setting of this illness? Is it possible? Is it not possible? Usually it's somewhere in between. And then we talk a little bit about what are the burdens of treatment that would need to be applied or would need to occur for them to reach that quality of life. And would they find it acceptable? Would it be acceptable to be in an intensive care unit on a ventilator for 2 months for a likelihood of 30% that you'll be able to breathe on your own? It's hard because we don't have answers and there's a lot of uncertainty. But that's the approach I begin to take. And then once we understand what's the goal? What are we hoping to achieve? What's the likelihood that we're going to achieve it? And what would be an acceptable likelihood? Then we talk about what are the treatments that we can use to meet that goal. And we select treatments that are consistent with that goal and are likely to be effective. And we discard or don't start treatments that are not going to meet that particular goal. And that's one of a series of conversations. Because if everything goes the way we hope it's going to go, we have a clear path forward. If things go in a different direction, then we continue to readdress what the patient's goals were or are, what the likelihood the treatment is going to meet them, and we make different decisions along that path. And at the end, what we hope is that when somebody survives, that's terrific, and that we hope that we've provided the best comfort and quality of care along that path. Although when somebody dies, we hope that they die with people, their family, feeling that their goals were met and their treatment they received was consistent with those goals all the way along, and who they were as a person.